मसला है।
वो सारे जो हैं उनसे आप कहें कि वो जो डायरेक्ट उसमें आ जाएं, ICD-11 की जो ईमेल उनको गई हुई है उधर से कनेक्ट कर।
ओके, राइट
लिंक की जरूरत नहीं पड़ेगी।
राइट।
लिंक की जरूरत तब पड़ेगी जब फर्स्ट टाइम ज्वाइन कर रहे हैं, बट अदरवाइज वो लिंक के थ्रू आ जाएंगे. So it's not necessary that they have to come through something else. आ तो गए हैं सारे कि नहीं आए? Still people are having problems.
तो प्रेजेंटेशन तो
yes,
आपकी नजर आ रही है।
चलो शुक्र है प्रेजेंटेशन नजर आ रही है, बस ये ज्यादा जरूरी है, बाकी हो ना हो. Okay, can you see the screen?
Yeah.
Perfect. Let's start. We are already 10 minutes late. Okay. Bismillahirrahmanirrahim. Last time when we started, there was a good thing and a bad thing. The good thing that people were very much enthusiastic to learn about ICD-11, but there were few comments that I have opened up a new Pandora box, which unfortunately I felt that I am guilty of, because I tried that you people should be updated about the new things. And in this process, I initiated teaching you the ICD-11. I told you about the website. Lots of people enthusiastically, they went on the website, they scrutinized the things, they studied from there, which is a good thing. And another good thing that you people did lots of advancement, like Kamran sent the new version of ICD-11, which I believe is not needed because everything is available online, so we don't have to rely on a book. And the second good part was Burhan worked a lot, so he was able to find an application where you can access it on your cell phones, which is an easy thing. So the good point is that people started looking at it and they started understanding it, which is a good thing. The bad thing is that lots of examiners probably now will be thinking about asking you the questions related to ICD-11. So I don't know if it is a bad thing or not, but I believe कि ये एक थोड़ी सी कॉम्प्लिकेशन हो गई कि बहुत सारे लोगों ने जाके अपने डिपार्टमेंट्स में बात की और उनके बात करने से वो नई चीज़ स्टार्ट हो गई. और जाहिर है जो who people are the new people coming in postgraduate programs, it's good that they are able to learn this. The bad thing, the old people like me have to update themselves, and update usually takes lots of time. So that was it. So the main thing that, just to recap from my previous presentation, that I told you about a website, ICD-11 website on WHO website as well. And you people are able to then see what is there, how it is utilized, what is MMS, the mortality, morbidity statistics, how can you use ICD-11 in your clinical practice, what are the, again, diagnostic changes that have been there, and you can update yourself. That is a good thing. The bad thing, again, as I said, that it's lots of work. And of course, I don't expect you people to learn everything about ICD straight away. I feel that it's a process. I'm learning, you will be learning, and hopefully it will help. So any disagreement to that? Anybody? No? Okay, let's. मेरी आवाज आ रही है ना?
Yes, sir.
Okay. Let's start about the important features of ICD-11. So today, the most of the presentation is actually related to the fact that I want to tell you the differences between ICD-10 and ICD-11, and some of the terms that are new in ICD. Hopefully, that will be helpful to you as well. So we already covered that ICD-11 is the lifespan approach, that is, disorders distributed to the groupings with which they share the symptoms rather than onset according to the age, resulting in a deletion of a group. Disorders usually occurring in childhood and adolescence. For example, separation anxiety disorder was shifted to the anxiety and fear related disorders. Similarly, culture-related information was systematically incorporated based on literature review on cultural influences on psychopathology and its expression for diagnosis, diagnostic grouping, as well as detailed review of culture-related material in ICD-10, CDDG, and the DSM-5, both. So lots of new things related to the culture, environment, social factors. Another major innovation was incorporating dimensional approaches within an existing categorical system. So they have tried to make sure that the axial system and also the categorical system of presenting a diagnosis should be corrected in a way that all the diagnosis can be filled up in one diagnosis. So there are dimensional classification focusing on relevant aspects of the clinical presentation, which is more consistent with recovery based on psychiatric rehabilitation approaches. The dimensional potential is robustly realized in the classification of personality disorders. So basic structure, the Kraepelinian organization of the disorders, followed by in ICD-10, was shifted to more scientific one. The organization principle followed a developmental perspective. Neurodevelopmental disorders appear first and neurocognitive disorders last in the classification henceforth. So previously, when you open ICD-10, the first chapter was neurocognitive. Now the first chapter is neurodevelopmental. So it is starting from the birth till the last part, which is neurocognitive end. So this is a change. So previously, the first was the organic, and then it was schizophrenia. Now it is neurodevelopmental, schizophrenia, and the organic component, the cognitive, is at the end. That is a major difference here. And disorders were grouped together based on putative shared etiological and pathophysiological factors, shared phenomenology as well. So if there is a term which is used differently in North America and differently in Pakistan, there is a shift from there. So everywhere it should be the same. The impractical organic, non-organic dichotomy is also considered. So previously, most of the time, we used to say this is organic, this is functional. So that is gone. Now everything is organic. Just like sleep and sex related disorders was discarded in ICD-11, while a separate chapter has been created for sleep-wake disorders that is relevant to all specialities. So now the sleep-wake disorders are not just organic or functional, they are actually just one, related to diabetes, related to hypertension, related to, again, jet lag phenomena, related to major morbidities in psychiatry, having sleep problems. Same goes for the sexual disorders as well. There was a chapter, transgender identity has been destigmatized by moving from mental disorders chapter to new sexual health chapter. So previously, transvestism, transfetishism, transsexualism, those were the terms used as a psychiatric morbidity. Now, because people felt that this is discrimination, so it was removed, and all of these things come in a sexual disorder chapter, whatever it is. So that is important as well. Catatonia, 6A27, 6A2Z dash block L 6A4. These are the ranges of the diagnostic places where catatonia is used. Very interesting question. Again, Manur asked me the same. What does this Z stand for? I was confused myself when she asked the question. Z stands for NOS, not otherwise specified. Now, in DSM-5, NOS carries lots of importance. So lots of people are diagnosed as psychosis NOS, schizophrenia NOS. Why this NOS? I was always again confused why they write NOS, not otherwise specified. But when you are practicing clinically, if a patient comes to you and he's been to at least, say, 10 psychiatrists before coming to you, or 4 psychiatrists before coming to you, he seems to be stable and no positive and negative symptoms of schizophrenia are there, and he is on antipsychotic. And you know that the previous diagnosis was schizophrenia. How you will label the person at this point in time when the patient is not having any active symptoms, but you have a feeling that the schizophrenia is still persisting. There are no positive symptoms, negative symptoms, hallucinations, delusions, anything. So how you will be able to label that? So NOS comes there, or Z category comes in ICD-11 related to that, where you'll be able to understand where you'll find it was schizophrenia, treated, symptoms remaining or symptoms gone, but patient is not functional. So this heading NOS or Z category is important here. The change in conceptualization of catatonia had been claimed for many years to give it an individual status, and this is for the first time catatonia was given the status of an independent syndrome. Now, catatonia is not related to one disorder, schizophrenia. Catatonia can be dissociative, catatonia can be in MDD, catatonia can be organic, and catatonia can be in dissociative disorders as well. So multiple psychiatric morbidities have catatonia. And this was one of the reasons why it was removed and given a separate. And it's very interesting, if you read the diagnostic criteria for catatonia, you will be surprised that probably we were missing 40 to 60% of the people having catatonia, and we were labeling them something else. So go through that and then definitely assess it. An entirely new diagnostic grouping for catatonia. Same hierarchical level as anxiety and fear related disorders, mood disorders, etc., has been added. 3 out of 12 core features are needed for the diagnosis of this syndrome. 3 conditions included in the new diagnostic grouping: catatonia associated with another mental disorder, catatonia induced by psychoactive substances, including medications, and secondary catatonia caused by medical condition along with addition of catatonia not otherwise specified. So this is very good. And again, if you read catatonia in detail, you'll be able to be surprised that patient was sitting in front of you, he was having catatonia, and you were not doing anything about it. So vision is broadened here. When there is a separate set of catatonic diagnostic criteria, now you can say that this patient suffering from major depressive disorder is having catatonia 6A to Z or anything like related to it. This is important. And if you work on it, you will realize that it's not so uncommon as we considered it to be. Previously, when catatonic schizophrenia actually is now masking away, the reason being that there are definite improvement in psychopharmacology. You see the patient, you give them the medication, the schizophrenia gets better, catatonia disappears. But now there are categories of catatonia which are very in milder intensity, not elicited clinically as we were eliciting them earlier. So we have to now understand catatonia in depth if we really want to, again, diagnose. And the treatment for catatonia is absolutely different in different mental disorders having catatonia, right? So unless or until you'll be able to diagnose it and label it, you won't be able to understand how to manage it. So it's a new dimension. And I believe that this is an excellent dimension where you can have lots of understanding and help you managing patients more well than it was in the historically back there. Bipolar disorders, type 2 disorders, block L 6A60. DSM-4 has already introduced bipolar type 2 disorders, requiring an absence of manic episode along with at least one hypomanic episode plus at least one major episode to diagnose. So bipolar 1 and 2 were not in ICD-10. Now ICD-11 has bipolar 1, bipolar 2, and it includes with supporting evidence of differences in antidepressant monotherapy response, neurocognitive measures, genetic effects, and neuroimaging findings between bipolar 1 and bipolar 2. There is lots of studies quoting that people who are having bipolar 1 have different findings in the brain as compared to bipolar 2. So if though both of the disorders have different neuroimaging findings, then of course they are different in nature. And of course the treatment strategy changes. And of course intervention and outcome changes as well. This is something new in psychiatry. And if we correlate genetics and neuroimaging into the classification system, whole bunch of responses change. So previously, people used to see a patient with schizophrenia, they were treating, a patient with bipolar, they were treating, and patient is not responding to one mood stabilizer, second mood stabilizer, combination, antipsychotics. Why? Because we were missing something in etiology, which was a positive finding in neuroimaging, or something positive genetically, which was refraining us to get the desired outcome as we want to. So there was continuous relapse and remissions, and we have to correct it. So this is a new category, and it obviously increases the dimensions. Body dysmorphic disorders. Now, this is again very interesting. 6B21 is the code, recognizing its distinctive symptomatology and similarities to obsessive compulsive disorder. Body dysmorphic disorders has been included in obsessive compulsive and related disorder. Now OCD and OCPD are changed to OCRD, including body dysmorphic disorders. And this is again very interesting for me. When I was going through it and reading about it, I got more and more enthusiastic about it because it's a whole new era in psychiatry. OCRD. People who are going to cosmetics, cosmetologist, or aesthetics, or dermatologist, or specializing in facial beauty. So you might have seen lots of our lead people in social media, especially the film actresses. They had the Botox, they had some implants, they had some correction of their nose through cosmetic surgery and all that stuff. Now, if you start looking at them and if you start relating it with the mental disorders, you will be surprised to know that lots of them will fit into the category of body dysmorphic disorders. मैं कैसी लग रही हूँ? I'm sorry, I'm doing this, but this is what a very typical sentence said by the females. मैं कैसी लग रही हूँ? If the person, it starts understanding कैसे लगने के साथ कुछ abnormal mental phenomena is happening, you will understand that there are lots of people, a very high morbidity of body dysmorphic disorder exists in our society and across the globe as well. Grouping in ICD-11, such inclusion excluded the confusion terms like hypochondriasis or dysmorphophobia and made it easy to differentiate from delusional disorders. So they are not actually delusional disorders, but they were considered as a delusional disorder, as dysmorphophobia was treated with antipsychotics previously. Now it's OCRD, obsessive compulsive related disorder. And when you know obsessive compulsive related disorder, everything related to the obsession comes to your mind. So the treatment strategy fails because dysmorphophobia won't be corrected with antipsychotics. Well, clinically, historically, which was done. Now it has to be treated like an obsessive related phenomena, OCRD, and the treatment changes as well. So there is a host of clinical impact on this diagnostic classification system. We may agree to some of it, we may not agree to some of it, but this is a new venture, a new pathway, a new way to move forward. I hope I am clearly mentioning about these. Olfactory reference disorder, block L126B2. In clinical settings, such conditions were not uncommon. This disorder is characterized by persistent occupation of emitting a perceived foul or offensive body odor or breath that is either unnoticeable or only slightly noticeable to others. मेरे मुंह से बू तो नहीं आ रही, chewing gum खा लें, right? And if this goes beyond that, and it is an obsessive phenomena, or we call it again, not obsessive phenomena, but if it is persisting to a larger degree and it is compromising your quality of life, we call it olfactory reference disorder. This is accompanied by repeated checking or reassurance seeking behavior and marked avoidance of social situations. Olfactory reference disorder is included in ICD-11 OCRD grouping. So sort of an obsessive phenomena, but not an obsessive phenomena, related to the smells, related to the body image, related to other areas, which I'll talk about soon. OCRDs have a big dimension now. And OCRDs is absolutely opening up a new clinical challenges for the treatment strategies as well. Hoarding disorders. Individuals affected by hoarding disorders are often under-recognized and under-treated, which argues from a public health perspective for its inclusion in ICD-11. Sufficient shreds of evidence support hoarding disorder as a separate and a unique disorder. Clinical characteristics were kept in line with DSM-5, that is, accumulation of possessions due to their excessive acquisition or difficulty in discarding them, regardless of their actual value. So when somebody keeps, say, I am keeping this with me because it reminds me of somebody, and if it is again not needed, not required in my daily activity, routine life. Previously, there was lots of debates about these kinds of objects, and they were called transactional object in psychology. Now it's a whole new era, which is again opening up as a hoarding disorder. Something I don't need it, but I don't want to throw it away. And despite the fact it's occupying a space in my house and making my house look ugly, I don't want to get rid of it. So like whenever in my family, I think about it myself, that I always say, okay, fine, this thing is not required, just give it to somebody else. Maybe somebody else needs it. But I don't want to throw it away because I have some emotional association with it and I want to keep it till the end of my life. And it's there, it's ugly, it's old, it's not liked by anyone, no more required for me for any usage, but then even then I keep it. Honestly speaking, if we try to treat this, I think half a population of the world won't suffer from hunger and death. Anyways, this is a long, different debate. Maybe sometime we'll have a different presentation on specifically these individual disorders and details related to it. I hope you are hearing me.
Yes, sir, we are.
Perfect. Thank you. Excoriation disorder. In view of similarities in phenomenology patterns of familial aggregation and putative etiological mechanisms, another new diagnostic subgroup naming body-focused repetitive behavior disorders has been added to OCRD grouping, including trichotillomania, was under habit and impulse control disorders in ICD-10, and a new condition, excoriation disorder, also known as skin picking disorder. And when I came to this country, I started seeing my patients. Lots of people, they are in habits of picking up their skin up to an extent that it sometimes injures the the person, lots of wounds on the skin. वो नाखून खा खा के खराब कर दिए, skin तोड़ तोड़ के जख्म बना लिए, and this is common. And when you go back and understand the pathophysiology of excoriation disorder, you will feel that most of the people fulfills the criteria of OCRD. So this is the reason why they have added it. Excoriation disorders and trichotillomania is distinct from OCRDs, as the behavior found to be rarely preceded by cognitive phenomena such as intrusive thoughts, obsessions, or preoccupations, but sensory experiences. So in a way, these disorders are related to OCRDs, but in a way they are not. So they have different pathology, they have different, again, backgrounds, they have different diagnostic points as well. So this was the reason why it was added separately. Then complex post-traumatic stress disorders, PTSD. The addition of complex PTSD to the ICD-11 is justified based on evidence of poor prognosis and benefit different treatment modalities as compared to individuals with PTSD. We always know that if somebody, I don't know how much experience you have in PTSD, but if somebody is having PTSD, the prognosis is very poor, especially if the PTSD is chronic, so say lasting for years. In America, lots of studies have been conducted on Vietnam veterans, which were returning from Vietnam War, which was about 3 decades ago, 4 decades ago now. They're still having PTSD, and they are having complex PTSD. And this is not uncommon. Again, consider yourself in this situation, lots of flooding around you, people losing their houses, people losing their money, financial things. This is actually a bad image. If I see a movie of some hotel drowned around the Swat River, of course, it can stay in my mind for years and years, and I can have complex PTSD, and nobody would be able to understand why I am having anxiety, depression, other symptoms related to sleep and all that stuff, unless or until the evaluation and assessment is completed in an appropriate way. We miss and then we lose. We won't be able to correct the things properly. So this is another. Prolonged grief disorders. Previously, we call it abnormal grief, or again, different name was given in different textbooks. In response to increasing evidence of a distinct and debilitating condition persisting for atypically long period following the loss, more than 6 months, that was not adequately described by ICD-10, prolonged grief disorder was added in ICD-11. Its inclusion and differentiation from culturally normative bereavement and depressive episode is essential because of the different treatment selection, modifications, implications, and prognosis. There's nothing much to be said. Binge eating disorders, frequent recurrent episodes of binge eating, once a week or more over several months. So this is again broadened. Previously, it was a continuous factor that person is binge eating. Again, people of Lahore love to eat food, and they are very fond of food. So many restaurants around, and they eat a lot. And this binge eating could be a disorder where probably 40% of the population of Lahore will be suffering if we start diagnosing them like that. So I don't know, maybe in times to come, we'll be able to label people like this as well, having binge eating disorders, nihariyan, pave, siripai, etc. Weight gain is not an essential feature, though might be present. Inclusion of binge eating disorders overlaps ICD-10 diagnosis of other specified or unspecified eating disorders. I hope I'm clear. Please, if you feel that you are not getting or you're not picking up the speed like I'm presenting, I thought I'll be able to finish it up today, but I don't think so we'll be able to do it completely, but I'll try. If you have any questions, please stop me and ask me that question. Another very interesting phenomena, avoidant restrictive food intake disorders. Again, young females, young males who wants to appear with good body and want to keep themselves very thin, skinny, lean because they are liked as a model, as a superstar, blah, blah, blah. 6B83. I'm not saying all superstars are having these psychiatric morbidities, but the reason to give you these examples is that if you look around you, you'll be able to find these people more again and probably common than, of course, the general population. Only patients coming to you should not be assessed. If you look around your society and you see them, these kind of disorders, you should be able to understand the dynamics as well. Avoidant restrictive food intake disorders. It is called ARFID, ARFID, ARFID. Like obsessive compulsive, OCRDs, these are ARFD, FIDs, is characterized by intake of inadequate quantity of variety of food to meet adequate energy or nutritional requirements in absence of concerns about body weight or shape. Difference from anorexia nervosa resulting in weight loss or failure to gain weight in childhood or pregnancy. To give you the example, again, young men goes to the gym and they try to make up their bodies, and it's a huge business now world over to have those kind of supplements which actually makes your body look nice. It's a big business, multi-billion, and one of the jars cost thousands and thousands of rupees, and people do spend it. $25,000 for one pack, which can make my body look good, right? I will lose my fat on the tummy. I will look slimmer, smart, healthy, handsome. Its inclusion can be considered to be an expansion of ICD-10 category, feeding disorders of infancy and childhood, and is likely to improve clinical utility across the lifespan. So it was not only for children. Now it is very much common in adults as well, if you really want to look at it. Body integrity dysphoria, a rare disorder characterized by the persistent desire of having a specific physical disability, for example, blindness, amputation, paraplegia, and deafness. You're never able to diagnose this earlier, never ever. I don't think so. I have ever diagnosed anybody with body integrity dysphoria. And when you read through it, you will understand, well, oh, this is not so uncommon as I consider it to be. Beginning in childhood or early adolescence, often manifested in fantasizing about having a desired physical disability or engaging in pretending behavior. For a few individuals, this desire or preoccupation goes far beyond fantasy and they pursue actualization of desire through surgeries. And this again, and this is getting very common now, especially with lots of people. I was surprised to see physicians doing aesthetics, surgeons doing aesthetics. Well, it's their job. Now, there are other specialties, people from other specialty who are doing the aesthetics, like anesthetist, like psychiatrist, and you look around and you'll be able to find them. They give treatment like this. In Pakistan, especially, I'm talking about, not otherwise. Of course, in rest of the world, it's not possible. Here it is. In Pakistan, lots of people practice as a specialist aesthetic person, and they have no qualification as well, which is unfortunately can be done in Pakistan. Gaming disorders, again, an interesting addition in ICD-11, 6C51. Gaming disorders has been included in a newly added diagnostic group called disorders due to addictive behaviors, which also contains gambling disorders in view of phenomenologically and pathophysiologically resemblance that become a global concern. So previously it was gambling disorder, now grouped together as addictive behaviors, Gaming disorder is one of the addictive behaviors, and this is 6C51. It is differentiated from non-pathological gaming behavior by the production of clinically significant distress or impairment in functioning. So people are crazy about cricket, people are crazy about hockey, people are crazy about basketball or something else. I don't know how much these games are anymore played in Pakistan, but yes, now people are addicted to this thing, cell phone gaming. And soon this gaming disorder probably will include these kind of games as well. You're sitting and you're playing the games. No matter how old you are, you spend lots and lots of time, which can compromise your functionality, quality of life, and you are hooked onto it. So it is gaming disorder 6C51. Compulsive sexual behavior disorders 6C72. This is characterized by a persistent pattern of failure to control intense, repetitive sexual impulses or urges for a minimum duration of 6 months or more, repetitive sexual activities becoming a central focus of the individual's life despite adverse consequences such as repeated relationship disruption, even when he or she no longer gets any satisfaction from it. So that thing which was there and you keep on doing something time and again, compulsive sexual behavior, watching pornography, masturbation, and all those kind of things, they come into this, where you don't feel pleasure, but you have to do it just to do it, right? Although this category phenomenologically resembles behavioral addiction, it is included in ICD-11 as impulse control disorder section in recognition of the lack of definitive information seeking, persuasions, and possible reducing shame and guilt associated with it. So people don't talk about this. Yes, it was difficult, and this is now a disorder. Okay, so I think I'm going too fast. I will try to control myself, my speed. I thought I will be able to complete it, but no, I won't be able to. Intermittent explosive disorder, 6C73. Although intermittent explosive disorders was introduced in DSM-3R, ICD-10, kept it as only inclusion term under other habit and impulse disorders, it is re-included in ICD-11, impulse control disorders section in recognition of substantial evidence of its validity and utility in clinical settings. Now, what is it? This disorder is characterized by repeated brief episodes of verbal, physical, aggression, or distraction that represents a failure to control aggressive impulses. And again, you will find it very common, very common. I'm sitting with, say, three children, and they start fighting with each other and hitting each other and then slapping each other. And sometimes people start enjoying it as well, which is strange, but it is true. So that unfortunately is a problem, right? So it is included in this disorder. Okay. Any questions so far?
Yes, sir, I have a question.
Okay, go ahead.
Sir, when you started the presentation, initially in some of the diagnoses, there was written block L. What is that block L? I couldn't find it anywhere. Matlab, am I missing out on something? What is that block L? What does it signify?
Block L. Okay, आप ICD-11 पे वापस जाएं, ओपन करें इसको, खोलें अगर खोल सके अभी तो
Yeah, sure. Just a minute.
ओके, उसमें खोलें, खोल के सिर्फ मेंटल डिसऑर्डर्स नहीं देखने, सिर्फ मेंटल डिसऑर्डर्स नहीं देखने,
Okay, sir.
ठीक है? ये क्राइटेरिया नीचे जाके 1 2 3 4 5 6 7 8 9 10 11 12 15 26 चैप्टर्स कवर हो रहे हैं, ठीक है? इन चैप्टर्स में okay, let me see how can I explain it to you. Okay, कोई मुझे नजर आ जाए तो मैं वो निकाल के आपको दिखा दूं. Visual system. You have to just go through it. You'll be able to understand that again various codings like E, C, N, D, Z, K, A, all of them are related to some kind. Now, it's not necessary that you will be able to find all the headings in mental disorders as well, because some of these things are described elsewhere but included in the nervous system as well, and in psychiatric and mental disorders as well. Next time I will try to explain that to you as well, because you asked a question about the Z, you asked the question about L. Z I explained to you, not otherwise specified, unspecified. L I will tell you soon as well.
Sir, I have one more question.
Go ahead.
So, if we have a patient with psychosis who is partially treated and currently there are no negative or positive symptoms present when the patient presents to us, and it is his first presentation at our setting. Okay,
Mhm.
so at
Okay.
that time, do we use the term non otherwise specified? No,
नहीं
I don't
समझ
think
गए.
so.
फिर बताएं.
Like, a patient presents to you who is partially treated for psychosis, and there are no positive and negative symptoms present on his first presentation. He has a medical record, and when first time he was diagnosed at any place, say at any other place, he was diagnosed as a case of psychosis, schizophrenia. But now when he has presented to
Okay, got it.
us, he
So
is
this is what
partially
I
treated.
started off with. I got it.
Yes,
This
yes.
is what I started off with it. NOS, when you read unspecified Z categories, it is always said, most of the Z categories, that the diagnostic criteria for the above disorder, like schizophrenia, patient is not fulfilling that at the time they presented to you. So patient was not able to say it, or you were not able to elicit it, that this person is suffering from schizophrenia, because there were no hallucinations, no delusions, but there were some behavioral symptoms, criteria in the criteria which they are meeting up. So, despite the fact they are on antipsychotics, so yes, in a way, yes, you can say this person is suffering from schizophrenia NOS or Z category, but in a way, no. Honestly speaking, I'm not sure when we'll be using it in clinical settings, what will be the outcome. For the time being, this theoretical background gives me lots of, again, stimulation every time I read about it, every time I see the things. You were asking me the question because I told you earlier as well. I'm new to it as well, because it's just been 8 months that ICD officially was launched. Although I started reading ICD in 2018, when the first time I just distributed ICD-11, but then it was not actually a regular feature because it was still evolving. So when they made it, there was different categories, and now it's different. Now everything is on website, so it's definitely is firm. So I'm not sure if you will be able to use both the categories together, but I will definitely respond to your this question and L category as well next time.
Okay, sir. Okay, sir.
What else?
Thank you.
What else? Anybody else? मैं देख नहीं पा रहा इसलिए मुझे नजर नहीं आ रहा वो. Any other question? No? Okay. Okay, so let's do two more disorders and then we will try to wrap it up. And the last 15 slides I will cover hopefully next time. And maybe I will add some more things into it, because every time I go through it, like you people have experienced the same as well.
Sir,
Every time
two
we
people have raised their hands.
go ahead, call them
Uh,
one by one.
one was me, and other is Dr. Abdul Rafi.
Um, it's me, Dr. Vinesh.
Okay, Dr. Ganesh.
Okay. Assalamu alaikum, sir. I'm
Walaikum
Dr.
salam.
Vinesh.
Yeah.
Question is not directly related to ICD-11, but it's something related to catatonia. In my ward, I received a patient with catatonia. She's mute, she's immobile. But my question is the catatonia is a presentation of severe depression? Like I have labeled the patient as affective catatonia. When I dig out the history, it seems like she has mood symptoms, she has depressive symptoms. But my question is the catatonia has a sudden onset, or is the patient has some mild or moderate depression that is going on, and finally when it comes to a severe extent, then she presented with the catatonic features?
Okay, so you have asked actually three questions. One, is catatonia can be part of MDD? Yes, it can be part of any psychiatric disorder. Second, is the onset acute or chronic? So both type of symptoms have been reported, acute symptoms as well. And now because people have started working on a lot on catatonia, so there is both type of onsets, insidious, gradual, slow, acute, and chronic as well. Third question, the treatment strategies of course change. Yes. So if the catatonia, so previously when I was just like you people as a resident working, so we were taught the definition of catatonia by our teachers, Malik Mubashir साहब, फरीद मनाज साहब. फरीद मनाज साहब उनकी definition बड़ी simple थी. Akinesis, mutism, relative preservation of consciousness. Patient is having again these symptoms, or movement abnormalities, or again with phantom pillow, whatever other things, echolalia, echopraxia. Now it is actually a very broad category. So if you feel that this is an extreme state of catatonia, yes, when you are able to elicit catatonic symptoms, it's a whole chapter now in catatonia, and multiple morbidities and multiple presentations and multiple disorders involved with catatonia, because it is linked with, again, our neuronal system. What is causing catatonia and how it can be associated with so many things. Yes, so it is possible. Maybe sometime I will present just on catatonia and I'll be able to explain that to you. But yes, response to your question, I think three questions that you have, I have given to you. It is possible. You have to be firm, we have to be sure, you have to be clinically sound to make sure that you are making the right diagnosis. Right?
Sir, just want to ask one more thing. Like, it is a feature of severe depression, or it can be associated like the patient has no symptoms of or sudden in onset.
It is not related to the severity.
Right, right. That's
It
what
is
I want to
not
ask. Thank you so
related
much,
to the
sir.
severity. No, no. Catatonia, now what they are saying, now what they are presenting, again, if I think of my clinical situations, I will definitely feel that yes, catatonia was much more common, and I was missing the diagnosis because I never had an idea about it. So yes, it is not dependent on the severity. It is not dependent on the chronicity, and it is not dependent on single morbidity. Got
Thank you
it?
so much, sir.
You're
Yes, sir.
welcome.
Thank you so much.
You're welcome. But of course, psychiatry, I get fascinated, I don't know, with my passion in psychiatry, teaching psychiatry for many, many years now. And what I have learned as a PG when I was a resident, and what the psychiatry is now, it's a whole dimensions have changed. And with each passing day, things are changing actually, and changing towards the good. Yes, we have a precise diagnosis, the treatment is easy. When you know the diagnosis, treatment is easy. When you don't know the diagnosis, the treatment is always, always difficult and complicated. Right? Okay. So there are people waiting in the lobby. Now joining at 12. Okay. No. Okay. So I am ending my presentation here. I apologize. I just usually have an hour with me, usually. So I don't have much of the time, but I will definitely. Oh, There are so many things in the chat box. No, it was transcript. Sorry. Okay. So anything else? Any question? Any query more than that? I'm sorry. I was rushing through today because we were late, and then I was not. I thought that I will be able to complete it, but I again feel that completing it in a rush will be not justified. So we'll do and be able to finalize it. I am stopping the recording.